So my talk will be about catecholamines, and I'll try to take you through the evidence we have regarding the use of catecholamines, some of my disclosures for the past 5 years. And we will begin with the guidelines, and we have a patient here. That's the guideline. We have a patient that could be any patient with acute heart failure. And it could be a patient with an acute MI, it could be a patient with a mechanical complication from an MI, or it could be a patient with myocarditis, whatever. But the first thing that we should do with these patients, according to the guidelines, is to do a bedside assessment of their hemodynamic profile. And we will do this by asking ourselves basically 2 questions. The first one is, does my patient have congestion? And we'll talk about symptoms and signs of congestion later on, but if the answer is yes, and the answer is yes in the vast majority of patients with acute heart failure, we'll call our patient wet. And if he doesn't have any signs or symptoms of congestion, then we'll call our patient dry. And the next question that we'll have to ask ourselves is, does my patient have poor perfusion? Now, this is trickier to assess, but again, I'll show you again the table. We have some ways of assessing symptoms and signs of poor perfusion. So once we answer these 2 questions, we'll be able to assign our patients to 1 of 4 categories. We can have our patient that has congestion but doesn't have poor perfusion, and we'll call him wet and warm. Then we'll have our patient that has both. We'll call him wet and cold. Then we have a patient that doesn't have congestion, but doesn't have signs of poor perfusion. And then we'll have a patient that doesn't have congestion, but does have signs of poor perfusion. And our patient in cardiogenic shock will be right here. It will be the wet and cold patient. And this is the table I was referring to before. The guidelines try to help us, giving us some symptoms and signs of congestion, both left-sided congestion and right-sided congestion. And they also try to give us a hand regarding the assessment of symptoms and signs of hypoperfusion. And you can see there on the right side, we will be looking for cold, sweated extremities, oliguria, mental confusion, dizziness, narrow pulse pressure, etc., etc. In the bottom part of the slide here, what you can see is some other valuable hints in the bedside evaluation of our cardiogenic shock patients. And we will look for hypertension, and here the cutoff is 90 milliliters of mercury, and we'll talk about it later on. Then we'll look for hypoxemia, we'll look for acidosis, we'll look for elevated blood lactate, and we'll look for oliguria. Now, I'd like you to realize that when we are assessing hypoperfusion, what we would really like to do is to try and assess microcirculation, because in truth, the ultimate therapeutic goal in cardiogenic shock would be to restore microcirculatory function, that is to restore an adequate oxygen supply. This is what goes first in cardiogenic shock patients. You have an increase in oxygen consumption, and you have impaired delivery and extraction due to the microcirculatory shutdown and shunting. And you can actually, as Professor Rins mentioned before, you can actually monitor this by sublingual perfused capillary density. So this is what we really like to look at, because what really has an impact on prognosis of patients with cardiogenic shock is the microcirculation. And I'm going to show you a paper that was published back in 2010. These are 70 patients with cardiogenic shock secondary to acute myocardial infarction. And what I'd like to show you here is that patient had a better PCD, that's perfused capillary density, had the best prognosis of, and they had, while patients had a lower PCD, had the worst prognosis. And this was also true after univariate and multivariate analysis. Please take a look at the right part of the slide, and you can see here in the multivariate analysis, the only predictor of mortality that is still there is PCD, and well, besides also the cardiac index, the cardiac power index. So it is very important. So once we think we know our patient hemodynamic profile, and we know that our patient is wet and cold, what the guidelines tell us, okay, is my patient hypotensive? And I mentioned this cutoff of 90 millimeters of mercury, and what I like to point out here is that this cutoff of 90 millimeters of mercury is completely arbitrary, and you've all seen patients that have a systolic blood pressure of 90 in your outpatient clinic, and they're perfectly fine, they're not in shock. And you've also, I'm also sure that you've seen patients in the emergency department that have an hypertensive acute pulmonary edema. And these patients are wet and cold, but they have a systolic pressure of 250 maybe. So again, systolic blood pressure, what should the cutoff be here? It's really difficult to tell. But the guidelines tell us, okay, if you have a low blood pressure, you should think about starting an inotropic agent, and you should also consider vasopressor in refractory cases. Use very cautiously diuretics, and then also consider using mechanical circulatory supportive in response to drugs. While if our patient does not have hypertension, then we should think more about vasodilators and diuretics and use only inotropic agents in refractory cases. So what we would really like to do with our patient is actually, if my patient is congestive and has hyperperfusion, I would like my drug, my Katecholamine, to be able to address these two problems. I would like my drug to be able to increase contractility, to be able to increase mean arterial pressure, to be able to also maintain diastolic blood pressure, increase cardiac output, improve regional perfusion, without increasing myocardial oxygen consumption. Also, we like our drug not to cause tachycardia or to be arrhythmogenic, and also to be able to use the drugs in a wide spectrum of patients, such as in pregnancy and pediatric patients. Also, from a pharmaceutical point of view, we like this drug to be non-toxic, stable, compatible with other drugs, peripherally deliverable. That is not true with most of catecholamines, with an easy titration, ideally a non-on effect, a steady effect without tachyphylaxis, and also, since we're having a wish list here, also to be this drug metabolized independently of liver and renal function. What we would also like is for our drug to be able to have beneficial effects on heart endpoints to save lives. And since we were asking also not to be too expensive. Unfortunately, we have none of this, because what we have, well, you all know, I mean, what we have increases myocardial oxygen consumption, increase myocardial ischemia, they can trigger arrhythmias, they can cause infarct expansion, they can worsen peripheral tissue perfusion and microcirculation, and they have shown no clear clinical benefit. Here is a table that I've made with the main drugs that we all have in our hospitals, and you can see here dobutamine, you can see dopamine, and dopamine is a tricky drug to use. You all know that the effect of this drug is very dose dependent. It's really kind of difficult to know what you're doing with dopamine with your patient. Then we have mildrenone, levosimendan, noradrenaline, and adrenaline. And I'm not going to tell you again about their mechanism of action. It's well known. What I'm going to try to show you is some of the evidence. And actually, what I was going to say, I'm not going to be able to show you any evidence on this for patients with cardiogenic shock, because these drugs have not been tested in good quality clinical trials in cardiogenic shock patients. What I'm going to show you some data, and this is fresh out of the oven. Thanks, Alex, for this. It's a paper that is in press in the European Journal of Heart Failure, and it's a sub analysis of the ESC HF long-term registry, dealing with the long-term safety of vasoactive medications in patients with acute heart failure. So you've got what you have on the left side is long-term mortality, and what you have on the right side of the slide is in-hospital mortality. And you can see here those patients that were treated with inotropes and or vasopressors had a worse prognosis with respect to patients that were not treated with these drugs. And you can see there the hazard ratio that is highly significant. And what is also interesting in this paper is the breakdown of drugs that we use in these patients. So you've got here this table, and here you've got your drugs, so the butamine, dopamine, levosimendan, norepinephrine, epinephrine, adrenaline. Very few patients, so it's not really possible to analyze this. But what came out of this is something that we're always suspecting, is that dopamine is not a very good drug to be used in cardiogenic shock patients. And as you can see here, dopamine in this analysis was associated with an increased risk of long-term all-cause death. What about noradrenaline? That's another drug. I think it's the most used vasopressor in cardiogenic shock patients. We don't have data for patient in cardiogenic shock, but we do have this trial that compared noradrenaline and dopamine in the treatment of shock of different origins. You have lots of septic shock patients here. You have hypovolemic shock and also cardiogenic shock. And well, they couldn't show any difference in the probability of survival between the two drugs, but noradrenaline here fared better for what adverse effects are concerned. There were a lot more arrhythmias and tachycardias with the dopamine than with noradrenaline. What is interesting here is that in the subgroup analysis, they found that patients with cardiogenic shock actually fared better if they were treated with noradrenaline with respect to dopamine. So this is, again, I think a consistent message across the use of vasopressors here. Dopamine, bad. Noradrenaline, I don't know whether it's really good, but it's better. I'm just sidestepping for a moment here, and I'm showing you a curious thing, because since we have no trials, well, but we're still using these drugs. And what I'm showing you here is the effect of noradrenaline shortage on septic shock mortality in the US. So this is a paper that came out in JAMA a few months ago, and you see here that 26 hospitals in the US had a shortage of noradrenaline. This is the baseline period. You see how the use of noradrenaline goes down here. That's a shortage period. It goes down because they didn't have any, and they used mostly phenylephrine instead. And what I'm showing you here on the right side of the slide is that in-hospital mortality for septic shock patients actually increased during that period. And it was an increase by, 4%. And with, I think it's a measure. We don't have a trial here, but of course, if we don't have noradrenaline to treat our patients with, then we really don't have a good substitute. Another issue here. So we have started an inotropic treatment in our patient with cardiogenic shock. But what if we really need a vasopressor right from the start? Well, this is a very interesting analysis of almost 1,000 patients with cardiogenic shock from 3 registries, the ALARM, HF, EFICA, and AHEAD. And what I'm showing you here is that the combined regimen of noradrenaline or vasopressor plus a nanodilator is better than to give the vasopressor alone. So this is actually very interesting, and this remain significant even after a propensity score weighting for a ton of variables, and it remained also significant in patients with, without ACS and with ACS. So how are we using catecholamines nowadays in our patients? Well, we are using them a lot. And you can see here, this is a recent publication from the Kardiogener study. And so you have here on top you have the vasopressors, and you can see here that in the Kardiogener study, 220 patients, 75% of patients received noradrenaline, 21%, lots of patients received adrenaline, 26% received dopamine, only 4% received vasopressin or terlipressin, that's some kind of rescue medication, and 30% of patients received both simultaneous vasopressors. Regarding inotropes, the most used one was dobutamine, followed by levosimendan, about 4% of use of mildrenone and oxymone and similar, and there was simultaneous use of a vasopressor and an inotrope in 55% of patients. So we are using a lot of these drugs. Another interesting data from this paper is that the use of adrenaline here was associated with a great increase in mortality. And what I'm showing you here is the Kaplan-Meier survival probability curves for patients that received adrenaline, that is down here, and other vasopressors. And what you can see here in the middle is the propensity score adjusted for all these variables that are here at the bottom of the slide. And you can see here that it was highly significant. No difference, by the way, between combinations of vasopressors and inodilators such as levosimendan or dobutamine. Why does adrenaline seem to be associated with an increase in mortality? Well, we have an hypothesis here from the same paper, and the use of adrenaline was related to deterioration in cardiac and renal biomarkers. And you can see here that patients that were treated with adrenaline had higher levels of high sensitivity troponin T. They had higher levels of BNP and also had higher levels of creatinine. So in summary, we are using a lot of catecholamines in our patient with Kardiogener shock. We cannot avoid it. 94% of patients received vasoactive medications. The association of different types of treatment with clinical presentation were very modest. There were no association with medical history, initial blood pressure, heart rate, of left ventricular ejection fraction. Mortality was 46% higher in patients treated with adrenaline. This is highly significant. And the use of adrenaline was associated with a worse evolution of cardiac and renal biomarkers, likely due to an increase in myocardial oxygen consumption, excessive vasoconstriction, or direct organ toxic damage. So we have all these drugs. We are using them, but why have we failed? And I'm showing you an interesting paper here. It's just 30 patients with cardiogenic shock, but it's a difficult study to do, and you will understand it. What they did here was they had 14 patients that were treated with the dobutamine. They did the before and after, 10 with enoxymone, and 9 with norepinephrine. And as you can see here, this is the baseline parameters were pretty similar in all patients, except for the mean arterial pressure that was lower in patients that were treated with noradrenaline. And this is the effect that these drugs had on microcirculation, the effect they had on sublingual perfused capillary density in individual patients. And you can see here that dobutamine didn't do anything. Enoxymone, it did something in some patients, but not in and the vast majority of them. And norepinephrine actually worsened the PCD. So my message here is that we have these drugs. They can improve parameters of microcirculation, but they fail in improving parameters of microcirculation. And we can maybe discuss why is this. Maybe we're not monitoring what we should monitor in our patients. What do the guidelines say? Well, the guidelines say what they can say. It's level C recommendations. They say, okay, use inotropes if you have a patient with hypertension and is in shock. You can think about using levosimendan or milrinone or noximone in patients that were treated previously with beta blocker. If you have to use a vasopressor, use noradrenaline. But again, here the evidence is sketchy, but that's what we have. Monitor patients that are being treated with inotropes and vasopressors. So my take-home messages, ladies and gentlemen, are we have a lack of evidence for clinical benefit for currently available inotropes and vasopressors. In spite of this, virtually all cardiogenic shock patients receive treatment with catecholamines, usually a combination of an inotrope and a vasopressor. In patients with immediate need of vasopressor therapy, the best combination seems to be with an inodilator. Adrenaline and I think also dopamine use seem to be associated with increased mortality. The treatment should be tailored by assessment and optimization on microcirculation target. It is okay to assess blood pressure, but it's not enough. We really have to monitor closely our patients. And finally, we do need trials to determine an evidence-based approach to vasoactive agents use, and this is really urgent. Thank you for your attention.